So I'll be quick. We will try to cover this as soon as we can, and I hope everyone can see the slides. I'll have a quick overview. This will overlap to some extent, so you can say this is an appetizer for the real meal that's going to come with Dr. Jacqueline Gold's presentation. So the WHO recommendation is obviously exclusive breastfeeding for the first 6 months and then to start complementary foods. And obviously you shouldn't stop the breastfeeding when you start. You should continue the breastfeeding as long as possible, preferably 2 years and beyond. The timing, again, the WHO recommends 6 months of exclusive breastfeeding. However, different bodies mention start time as early as 4 months. It shouldn't be before 4 months of age because the baby is not ready, both from the GI perspective, and there is some evidence that if you start early, there may be a risk of obesity, especially in the formula-fed babies. However, you shouldn't delay it much longer as well, because if you delay beyond 24 weeks or 6 months, the baby may start refusing, and there is also micronutrients like iron and zinc, which may be deficient for the growing infant. So it's important to time the weaning according to the convenience between 4 and 6 months, preferably in breastfeeding babies, wait till 6 months and start. And how do we assess if the child is ready? So we can assess by looking at the good head control of the baby, ability to sit with support, shortened intervals between the feeding. So the child is starting to look for more and is getting hungrier. When you are eating, the baby opens a mouth, or when you present the food, the baby opens a mouth. So this is a sign that the baby realizes that food is to be enjoyed. There is also a diminished extrusion reflex where the tongue rises and pushes against any object that's placed in the lips. So the food will be pushed out. So this has to reduce before the baby can eat. However, when you start, baby can show this and then grow out of it. So as I mentioned, showing interest in what a caregiver is eating is an important sign, and they should turn the head away from the breast or bottle when they are done. This most babies are able to do by 3 to 4 months. However, this is an important sign as well. So what do you introduce first? I'm sure Dr. Jacqueline will touch on this in a detailed way. I mean, cultural factors play a big role, because where you are from originally, what your parents and your family advise you will guide a lot. So first, offer a variety of single ingredient fruits, vegetables, grains, and meats in any order. And you allow the baby to become accustomed to diverse flavors. So don't stick to just one type of food. It's very important that we tell the family there should not be any honey used in the first year of life because of the risk of infant botulism spores being present in it. Whole milk is, any animal's whole milk is not recommended in the first year. We shouldn't add salt or sugar, and there shouldn't be any sweetened beverages. We should avoid excess of rice-based weaning, like in some countries like India they do, as the arsenic load may not be good for the baby. We should give a mix of oats, wheat, and other grains. And at the same time, don't give excessive wheat because of the gluten sensitization risk. And in terms of introducing allergenic foods, again, this is going to be mentioned by Dr. Gold. The current evidence shows that there is no benefit in delaying the introduction of allergenic foods. Such foods can be introduced in culturally appropriate fashion anytime after 4 to 6 months, after the non-allergenic foods are tolerated. In infants at high risk of allergy, studies like the LEAP study have shown that introducing peanut, for example, in appropriate form, that means like a paste or peanut butter, between 4 and 6 months showed a lower risk of allergy in those at risk. So about 25% reduction in risk is there with this approach. So there is also evidence similar to the above with potentially allergenic foods like egg, fish as well. And we should remember to introduce eggs in a cooked and not raw form, and introduce fish one species at a time. The protein-rich food like pureed meat and chicken can be introduced by 6 months. We should keep this in mind that protein in the diet is very important for the child's growth. And most of the potato and vegetable foods do not have significant protein content. Dairy products like yogurt, cheese, so like the low-salt variety of cheese like mozzarella can be introduced. Ghee, butter, according to the culture, can be introduced by 6 months as well. Breast milk or formula milk can be used for preparing the food for the baby if needed. I mentioned that egg should not be partially cooked or raw because there is a risk of salmonella infection. Fish, as I mentioned, it should be introduced by 6 to 8 months as culturally appropriate. And if you are using nuts, nuts are a good source of protein, and vegetarians might benefit from dairy protein and nuts, and you should use it in the age appropriate form, for example, in butter form or a powder form added to the foods around the same time. We should, in a vegetarian family, we should look into the details about introduction of protein, because vegetarian foods are not that rich in protein. So soya, dairy proteins, nuts and pulses should be there along with the cereals. And we also need more iron and multivitamin in these babies. So some tips: ensure that adequate water intake is there when we give foods, and increase the water intake if the stool is hard. This is a common scenario. Juices are common. I mean, parents think juices are good, but please guide them that juices are not really good as for the developing teeth as well. And fresh fruits in a mashed or pureed form are more nutritious. However, you should avoid prolonged contact with sweet foods like the fruits. Like there is an option now with strainers where the baby sucks on it and the fruit pulp goes through. That is not good for the developing teeth. And focus on dental hygiene from the early stages. When they come to you for the 4-month vaccine, tell them about the dental hygiene as well. Start reducing the milk intake in balance with increasing solids. And the last couple of slides, we should have some baby-led weaning. The baby enjoys handling food. Baby likes to be dirty. And so finger foods like cooked carrot slices, cucumber slices, cheese slices at appropriate finger age-related food should be encouraged. However, a total baby-led weaning can be confusing for some families. So do a mixture of both. Avoid being too rigid and encourage experimentation. At the same time, obesity is a risk, so avoid forcing to finish a quantity. Around 8 to 9 months, the baby is very independent. They don't like to be pushed. So remember that food aversion is a common complication of our own overzealousness to introduce more food to them. And if the baby keeps drinking milk, they're not going to be hungry for solids. So reduce the milk as we go on. Avoid giving the same texture. And when we give over reliance on ready-made weaning foods in jars, this texture change doesn't happen. So experiment more, and that way baby will take more variety. And same way with the granular or chopped food beyond 9 months. So we can give toasted bread and so on with different textures. So babies don't reject such foods. So if you have a delay in introducing such foods, babies tend to get stuck on pureed food. So I often get 15-month-old, 18 months old saying my baby doesn't take more than pureed food. So this is because they delayed the introduction, and you have to change the behavior over time. And avoid compensating with milk. Suppose the child refuses a meal on a certain day. We are hungry on some days, we are less hungry on some days. The same happens with babies. When they're teething, they may be irritable, they may not want to eat much. So don't immediately substitute with milk when they eat a little less that day. And don't bring in favorite foods like biscuits or anything like that. If the regular options are refused, try to wait a little bit. The child will come over it. Eating together or sharing from your plate encourages the trying new textures, and encouraging competition between siblings. And if you have twins, obviously between the twins as well is a good way to come over this reluctance of the baby. In terms of dietary supplements, this is the key topic that Dr. Gold will be speaking on. So vitamin K is given at birth because breast milk is deficient relatively. Vitamin D drops 400 units per day is recommended in both breastfed and formula-fed babies from birth. After 4 months, we consider a multivitamin, especially in breastfeeding babies. The formula-fed babies get multivitamin from the formula milk at least till 6 to 8 months. And iron supplements are started at 4 months in breastfeeding babies and by 6 months in formula feeding babies. It's not essential if you start meat and chicken products early in these formula fed babies. However, in breastfeeding babies, we continue it till they are about a year old. When introducing complementary foods, consider iron fortified or iron rich foods. This is very important. And remember, DHA supplements, fish oil or fish intake should be encouraged. And most of the countries here do not have fluoride in the water. So remember that a fluoride containing toothpaste is introduced as soon as the baby starts teething. Continue these at least till 1 year of age, preferably till 2 years. However, some guidelines like UK suggest that you continue supplements till 5 years. So coming to the last slide, I would like to thank Dr. Taufik for mentioning my YouTube channel for parent education. There is a lot of information for pediatricians as well. So I would encourage you to subscribe and share it. And it's my pleasure now to introduce Dr. Jacqueline. Dr. Jacqueline, please open your mic. She is a very reputed speaker. She is very experienced. She is a doctor of philosophy, pediatrics, and reproductive health in the University of Adelaide, Australia. She has done a lot of research in the field of nutrition supplementation. She has chaptered as well as written textbooks. She has given lots of lectures all around the world. She's a world leader on the topic, so to speak. Dr. Jacqueline, I'm sorry I stole some of the information you had before you could start, but this is just an appetizer, as I said, and I'm sure you have far more interesting stuff in much more detail to share with us. So the floor is yours, and we will have questions at the end, and please enter the questions in the question section, and avoid chatting during the presentation. Thank you for all your support.
Yeah. Thank you for that lovely introduction, and to Nestle and for organising this, and everyone for giving up their time to hear about complementary feeding. Okay. All right, so my background is really mainly in psychology, so I'm going to be talking a bit about complementary feeding, specific micronutrients, and developmental outcomes of babies. So I'm going to give a very brief overview of why the complementary feeding period is so important, what nutrients are important, and really focusing on iron because it is a problematic nutrient during the complementary feeding period. Then going to give a little bit of an overview of some of the recommendations and the evidence around complementary feeding, and a little bit of an update of what complementary foods are actually being provided at the moment in the US. And then we'll have a bit of a discussion. Okay, so as I'm sure you all know, the first 1,000 days are considered to be a period of incredible importance for optimizing the health and development of an individual. And one of the most important factors is ensuring appropriate nutrition during this time. So after birth, nutrition is really essential for ensuring that growth happens according to the trajectory that it's meant to. So in the first 24 months of life, a child reaches around 50% of their adult height, and the brain goes from about a quarter of the size of the adult brain to 80% of the adult brain. So that's a huge period of development, and the processes of synaptogenesis and myelination are really critical in this time. Now, growth and development is of course genetically predetermined, and we can't alter genetics. So nutrition is the second most influential factor, and this means ensuring all the right nutrients at the right time. Without optimal nutrition, we have lifelong adverse consequences when deficiencies occur during the complementary feeding period. So it really is essential to get all the nutrients that are necessary to avoid stunted growth, and at the other extreme, to avoid obesity in later life, to protect against a range of different chronic diseases and morbidity and mortality, and of course for brain development. So nutrients throughout those first 1,000 days are crucial, provided through the placenta before birth, through breast milk in the early months or through formula, and then complementary feeding. Now, complementary feeding is a period that's high risk for nutritional deficiencies and sometimes excesses as well, but we'll focus on deficiencies today. So part of the reason why it's so risky for deficiencies is that the needs of the infants are incredibly high, and this is because they are growing at such a rapid rate and they're developing so quickly, and they have quite a high metabolic rate. It's also a time when there are huge changes to the diet, where the infant is going from a purely milk-based diet with increasing new foods and new textures, and the infant can only consume so much food in any given day. So it's really important that breast milk feeds or formula feeds continue, and they shouldn't be overly interrupted by the introduction of complementary foods. And when complementary foods are provided, they need to be chosen carefully to make sure that they are going to ensure adequate nutrients and that they're hygienic, so that they're not going to make the infant unwell. It's also a time when some nutrients that are in high demand are not necessarily readily available, especially products that are, or nutrients that are in animal products. Now, nutrients are, of course, the building blocks of the body and the brain, and you can see although water is the main component, lipids and fats come pretty closely afterwards, followed by proteins and carbohydrates. Now, along with being the building blocks for our bodies, the nutrients are also needed for everyday functioning, maintenance, movements, learning and development. And during the complementary feeding period, when the brain and the body are growing so rapidly, there's a little bit of competition between the needs of the brain and the needs of the rest of the body. Now, just quickly with macronutrients, obviously energy is really, really important for both development and growth and maintenance of the body. And during infancy, there's such an increase in physical activity levels where, as a young infant is quite immobile and spends a lot of time sleeping, whereas a 2-year-old can be quite a bit more active. So going back to lipids, when you think about the brain, although most of it is water, when you take away the water, 60% is made up of a variety of different lipids. And there's a little bit of evidence to suggest that there are protective mechanisms in the brain where if a specific sort of lipid is deficient, there will be compensatory increases in other sorts of lipids. And we see that in particular where if there's a little bit lower omega-3 fatty acids, there'll be a replacement with omega-6 fatty acids. Now, fats and lipids are crucial parts of cellular membranes throughout the body, but they are particularly concentrated in the brain. They have a role in cell signaling, proliferation, and differentiation. And of course, they're the main component of myelin, hence the name, the fatty sheath that myelin has. Now, dietary deficiencies don't necessarily have clear impacts on the brain, but we do know that severe lipid deficiencies, which are usually from metabolism disorders, have long-lasting effects on the synthesis of myelin with results as global delay, poor muscle tone, seizures, and neurosensory impairments. Protein, of course, has a really important structural role throughout the body and the brain. It makes up around 30% of myelin, so as myelin is being formed rapidly during the complementary feeding period, this is really important. It has a range of roles in cell membranes, in forming different signaling molecules, neurotransmitters and enzymes throughout the body. It is of course important for growth, and where there are insufficient energy in the form of carbohydrates and lipids, protein can be used as a source of energy instead of for structural purposes. And deficiency is likely to cause poor growth as well as poor motor and cognitive development. Now, carbohydrates are one of the main sources of basic energy. They're essential for the maintenance of metabolic processes that are necessary for everyday functioning as well as development. They're really crucial in the brain for neurotransmitter production and maintaining synapses once they've been formed. And during early infancy, synapses, which are connections in the brain, are formed so rapidly. It's, as the little infographic there says, there are 700 formed per second. That takes a lot of energy. And then once a synapse is formed, it needs a lot of energy to keep it maintained. And that's one of the reasons why later in childhood, synapses that don't get used get pruned away. So the brain, despite being only 2 to 3% of the body's weight, actually accounts for about 20% of the body's basic energy usage. It needs huge amounts of energy. So when we have malnutrition in the form of basic insufficient macronutrients, one of the first things that you'll notice is slowed growth. So an infant might stop their growth trajectory, or they might start falling below where you would expect them to. As it gets more severe, infants can experience failure to thrive and stunting with subsequent poor cognitive and motor developments. And part of this could be because there's not enough nutrients for brain development, but part of this is also linked to fatigue causing reduced exploration and engagement and opportunities for learning in the environment, which then mean that there's less stimulation for the infant and reduced synaptogenesis. So this figure gives a little bit of an overview of how basically how that interaction might work. So where there's a poor nutritional status, an infant is going to have less physical energy to interact with the environment. They're probably more likely to be unwell and more likely to be unwell for longer and take a lot longer to recover. Their growth will be slowed, and then there are subsequent effects on exploration of the environment, even their interactions with their caregivers and other family members, reduced opportunities for social development and for learning. And then that's when you see these adverse effects to cognitive, motor, and social, emotional development. So infants with malnutrition that's severe enough to induce stunting or wasting have shown to have poorer development of IQ and cognition and poorer motor skills. Once they hit school age, they don't do as well as infants who have sufficient nutrition. They're more likely to have behaviour problems, and even as adults, they're likely to have a reduced work capacity. So although this malnutrition might occur quite early in life, the effects do last a long time. Just to give you a bit of background on a few of the key micronutrients during the complementary feeding period, vitamin B12 is really important for the production and maintenance of myelin, the production of neurotransmitters, and maintenance of the central nervous system in general. So when there's deficient vitamin B12, there's a possible degeneration of the spinal cord, and this can be initially present as loss of sensation from peripheral nerves, so things like fingers and toes. As the deficiency becomes worse, there can be difficulties with motor movements and eventually memory loss, confusion, and delirium. Iodine is necessary for thyroid hormones, which have a role in general brain development, and iodine deficiency in those first 24 months has been shown through a range of observational studies in areas where there's just endemic total deficiency of iodine in the diet. Effects are go from mild deficiency with slightly lower IQ to intellectual impairment, stunted growth, quite severely lower IQ, goiter, and cretinism. And again, an infant who is affected by iodine deficiency to this extent doesn't recover even if iodine status is supplemented and is corrected later on. So again, these are lifelong adverse effects of deficiency. Zinc has an important role in quite a few proteins, for things like enzymes. And in animal models, zinc deficiency is suggested to lower activity and hence motor development. And then this is thought to have a similar effect to general macronutrient malnutrition, where there's going to be less engagement with the environment and poorer developmental outcomes. Now, iron is the really key one in the complementary feeding period. Obviously, iron is necessary for transporting oxygen from the lungs throughout the rest of the body, and oxygen is needed to convert glucose into energy. Now, remembering that the brain uses around 20% of the body's glucose supply, it also uses around 20% of the body's oxygen. So it is very much affected by lack of iron. Now, iron is, of course, in a range of proteins along with hemoglobin and proteins that are important for brain development, and so we do see effects to brain development when there is insufficient iron. Now, during the 6 to 12 month period, iron requirements are actually higher than they are in any other time in the lifespan. And normally during the last trimester of pregnancy, the infant builds endogenous stores of iron that are meant to last them for around 6 months. But at this time, if an infant is exclusively milk fed, whether it's breast milk or formula, they are likely to become low in iron if they don't have complementary foods that contain iron. Now, breast milk contains low levels of iron, and that doesn't change even if you supplement breastfeeding mothers with iron. But it's interesting that iron in breast milk is highly bioavailable, so it does get absorbed by the infant, but the levels still are quite low. So it's quite commonly accepted that breast milk alone after 6 months of age is not adequate to prevent iron deficiency in most infants, even if they're otherwise healthy. So more than 90% of iron during the complementary feeding period needs to come from complementary foods, whether that's fortified weaning foods, iron fortified formula, or foods that are naturally rich in preferably bioavailable iron. Because this can be tricky, iron deficiency is one of the most common nutrient deficiencies worldwide. Iron deficiency anemia is the most common form of anemia, and it is most common in young children and during pregnancy. So there are a range of effects of inadequate iron on the brain and brain development, and if that's just low iron, and if iron deficiency is sufficient enough to cause anemia, there's not enough iron to produce hemoglobin, and effects of anemia include lethargy and fatigue. So there's a reduced capacity to explore and learn from the environment and engage with caregivers and family members. Increased risk of infection, and infants who do become sick are more likely to be worse off, take longer to recover. Their growth can be slowed, and altered brain development as well. So observational studies of infants who are iron deficient before they hit 24 months have shown that at the time of the deficiency, they do show signs of fatigue and poor concentration and interaction with the environment. As they get older, they have an increased risk of poor cognitive and intellectual, motor, emotional, language and behavioural development. And even when they hit school age, they're likely to do worse at school. And this is regardless of whether or not they receive iron supplements later on and have their iron status corrected. In case control studies of healthy term infants that are iron deficient, they've been shown to have an IQ that's 6 to 15 points lower than healthy infants that are not deficient in iron. And this is quite a huge difference when you think that an IQ is standardized to have a mean of 100 and a standard deviation of 15. So you're seeing a difference here that is a third of a standard deviation to an entire standard deviation. Motor scores are around the same. So, and this is the same sort of standard deviation where you expect mean of 100, standard deviation of 15. So these are quite substantial effects. And social and emotional outcomes are worse off as well. So infants are more likely to be very wary and cautious, but sadly also unhappy and more likely to be anxious. And again, these deficits do tend to last even when there's iron supplementation after the period of deficiency. Now, in Australia, we're lucky that we tend to be quite nutritionally replete, but we do have a really strong focus in the complementary feeding period in ensuring that there is iron-rich foods provided to infants. And it really is highlighted that iron-containing foods, particularly meat and fortified infant cereals, should be the first complementary foods provided to an infant. And then once infants are established with their complementary foods, it should continue to be provided. So there are two forms of iron in food. There's heme iron, which is considered the more bioavailable iron. So the body absorbs around 25% of that iron, and that is iron that's present in meat and animal products. Non-heme iron is not as bioavailable, so it's not as well absorbed, and this is the iron that's present in infant cereals, in vegetables and in legumes. Now, infant cereals are usually designed so that with the awareness that not as much might be absorbed, so the dosage is usually quite a bit higher. You can also increase the amount of iron that's going to be absorbed by obviously providing vitamin C rich foods along with the iron containing food. So if we have a look at a bit of the evidence around iron in complementary foods and development, an observational study in a reasonable size sample looking at meat intake during the complementary feeding period was able to show a positive association with later motor scores, still in the complementary feeding period. But a range of randomized control trials, all in for a randomized control trial, they're rather small samples, have given iron supplements or a placebo and measured mental or cognitive and motor development. And although they found that the groups didn't necessarily differ, most of their samples were deficient in iron and had poor scores before the intervention and tended to catch up in their scores a little bit after the iron intervention. So there still was some benefit to these infants. If you're looking at sources of iron, there's been one randomized control trial that has compared pureed beef versus an iron-fortified infant cereal as the first complementary food. And they found that there was no difference in Bayley's mental or motor scores. And Bayley's is one of the main tests that's used to assess development early in childhood. So it suggests that there's no difference between beef or infant cereal as one of the sources of iron during the complementary feeding period. Now, there is a little bit of hesitancy to supplement iron in all infants, which is why in a country like Australia, we don't necessarily recommend supplementation as opposed to providing foods that are rich in iron. In this one of these studies, we had a randomized control trial of 3 different groups in an area where malaria was endemic, as was iron deficiency. So what they did was they had one group that received no iron, two randomized groups. One group that received no iron and another group that received a fortified cereal. And they found that they were able to slightly decrease the prevalence of anemia, but anemia was still quite common, so it wasn't necessarily iodine deficiency anemia. They did increase iron status. They didn't increase iron status, and they found that there was still a really high prevalence of malaria in both of the groups in this study. So there are some concerns around providing iron to infants that are at risk of malaria. In another randomized control trial in breastfed infants, where there was a population in Sweden and in the Honduras, they compared, this is the one with the 3 groups, no iron in one group, iron from 6 to 9 months in another group, and iron from 4 to 9 months in the last group. And they actually found differential effects of the iron supplementation depending on whether or not infants had adequate iron status to begin with. So if hemoglobin levels were low at the beginning of the study, they actually found that it was beneficial for prevalence of diarrhea, but diarrhea was actually worse in those who had a sufficient iron status already. They also found in the Swedish infants, which were more likely to be nutritionally replete, that iron supplementation also had a possible negative effect on growth. So it is something where there's still a little bit of a debate around how much iron is too much iron, and there are also some suggestions that over supplementation of iron during pregnancy may have subsequent negative behavioural outcomes on children as well. So it's something to consider. Still, in most cases, you're looking to prevent low iron and iron deficiency. And when you have healthy term infants, for most of them, starting iron-rich foods as complementary foods by or at 6 months is going to be enough to ensure that they don't become iron deficient. Starting iron-rich foods after 6 months can contribute to iron deficiency because their endogenous stores are going to be running quite low. Now, ensuring that iron-fortified cereal or pureed meat are introduced as some of the first complementary foods is going to be crucial. And if you're using infant cereal, it's really important that it's actually mixed with either water, regular breast milk, or formula rather than with cow's milk. You can also avoid infants having low or becoming low in iron by avoiding early umbilical cord clamping. ensuring that they have an ongoing variety of food as complementary foods that include sources of iron, avoiding cow's milk until after they hit around 12 months, and after their 12 months, minimize cow's milk to less than 2 cups a day. And of course, avoiding foods or drinks that are going to interfere with iron absorption. Now, that was all for infants who are healthy and term-born infants. There are infants who need to be handled differently because they're likely to be of higher risk of having iron deficiency. So these include infants who are born preterm, and this is
Dr.
because...
Jacqueline, sorry to interrupt. I think your voice is drifting a bit. Do you want to have a quick drink of water?
Sure, thanks. So it's getting to about 1:30 in the morning here, so I'm not normally talking so much at this time. So infants are more likely to be at risk of iron deficiency if they were born preterm, and this is because the majority of infant iron stores are built up in the last trimester of pregnancy. So the earlier an infant is born preterm, the less of that iron storage, the less of that iron supply they're going to have. Babies with a low birth weight or small for gestational age or growth restriction are also likely to have reduced iron, and this is because there is an issue with the nutrients they're receiving from the mother during pregnancy. Babies born to mothers with poorly controlled diabetes are less likely to have sufficient iron, and this is again related to the effects on growth during pregnancy. Babies born to mothers who are anemic during pregnancy are thought to have lower iron stores, but studies that have looked at this have been quite inconclusive so far. And infants with gastrointestinal disorders, even if they're being provided complementary foods with iron, doesn't necessarily mean that they're going to be absorbing the iron. So it's important that the underlying condition is diagnosed and handled properly, as well as ensuring that they get enough iron. Some babies might be at risk of becoming low in iron just because they're growing rapidly and they have a higher requirement, so they burn through their endogenous stores more quickly. Babies who have had their umbilical cord clamped early, babies who have been fed cow's milk instead of breast milk or iron fortified formula during the first year of life, and babies who are provided with a vegan or a vegetarian diet where sources of iron in the complementary foods haven't been really well considered. So if something like iron fortified cereal is being supplied regularly, they might be okay, but it is best if there is oversight from an experienced dietitian or pediatrician. Now, if iron levels are deficient, and particularly if there is iron deficiency anemia, it's really important that iron-rich complementary foods are provided on a regular basis. So, a couple of times a day from 6 months onwards at least. And this might take quite a bit of counselling to make sure the parents have the awareness and the knowledge of foods that contain iron, and that they pair those foods with vitamin C containing foods to make sure that the iron is absorbed. It's probably also going to be necessary to include iron supplements as well. For infants, there's usually drops or syrups, particularly for infants that are preterm and low birth weight, and it's, where feasible, it's best if there can be ongoing monitoring of not only iron status, but of their symptoms and making sure they improve, so that you're not over supplementing iron. All right, so taking a step back to have a look at complementary feeding as a bigger picture. The World Health Organization defines complementary feeding as the process starting when breast milk doesn't meet the nutritional requirements and additional foods and liquids are needed, and that this is from 6 months of age to 24 months of age. They have a range of recommendations, but the main one I want to point out is that they recommend that complementary feeding starts at 6 months of age with small amounts of food, and then this gradually increases as the child gets older. So does the consistency and so does the variety. There is a little bit of debate internationally around the ideal age for introducing complementary foods, and I'm going to go through a couple of recent reviews by the European Food Safety Authority and ESPGHAN that have specifically looked at the effect of timing of complementary feeding on a range of outcomes. So when we're talking about growth, both of the reviews have looked at whether or not there's any effects of introducing complementary foods before 6 months or at 6 months, and found that really there's no evidence of a benefit or harm on growth, obesity, or BMI. They did state that most of the studies that they looked at were quite robust, but they were mainly all within the first 12 months of life. So effects on later childhood growth and obesity are not well understood. There was also a report of a possible risk of later obesity for complementary foods that are provided, so when complementary foods are provided less than 4 months. And the evidence for this was mainly driven by a randomized control trial of complementary feeding that recommended complementary foods were introduced either at 3 months or at 6 months. And this study was quite large and quite well done. They did find that at 12 months, the early introduction group had a higher BMI, but by 3 years, there was no difference. So this was a secondary outcome from the study, so it does need to be interpreted with caution, but it is something worth considering, especially with the rise in obesity and overweight in childhood. Now, allergic disease is becoming an increasing worry as well, particularly in Western developed countries, and there is a lot of interest around this area. So the studies that have been done so far suggest that introducing complementary foods at 4 to 6 months has no effect on a range of different allergic disease outcomes. And looking at the introduction of specific complementary foods during this period shows that there might be an increase in the risk of allergic reaction for raw or partially cooked chicken eggs, but no effect if the eggs are well cooked, if they're 4 or 6 months. Also, no effect of the timing of introduction of peanuts if they're 4 months versus 6 months. However, in the main study that looked at this, they actually recommended some of their families avoid peanut until around 5 years of age, and they found that there was quite a significant increase in peanut allergies as a result of this avoidance. So the evidence is suggesting that for most allergens, early and regular exposure is more likely to result in less allergic disease. For gluten, there was no effect of timing, whether gluten was introduced at 4 months versus 6 months on celiac disease, but they did recommend that as gluten is introduced, it's best if the infant is still breastfed. Now, there's one study in particular that I wanted to highlight with allergic disease because it is one of the largest to look at trying to prevent allergic disease, and this was the EAT study in the UK, where they had over 1,000 exclusively breastfed infants, and they randomized them to either introduce 6 allergenic complementary foods at 3 months of age, or to follow the current dietary guidelines in the UK, which were to introduce complementary foods at 6 months, and there was no specific instructions around allergenics. Their primary outcome was the prevalence of food allergy, any food allergies between 1 to 3 years of age. And when they did their intention to treat analysis, this was looking at what happened according to what families were randomized to do. They found that there was no difference in food allergies, regardless of whether they were in the 3-month or the 6-month group. But when they did their per protocol analyses, which is looking at whether or not families followed the instructions that they gave them, they actually found that the 3-month group had a significantly lower risk of food allergies particularly in relation to peanut and egg allergies. And they also found that the efficacy for preventing allergies was related to both the duration and the quantity of the allergenic complementary foods that were provided. If we're looking at effects of the timing of complementary food on infection and illness, both the food safety and the ESPGHAN reviews concluded that so long as food is hygienic, there's no effect as to whether it's introduced at 4 months or at 6 months, so long as the infant's developmentally ready to have complementary foods. So they found no differences in gastrointestinal infections, lower respiratory tract infections, or infections in general, but they did have a question mark around upper respiratory tract infections, and this was mainly due to the EAT study again. So here in their 3-month group, they found that there was slightly higher upper respiratory tract infections, no difference in any of the other infections or illnesses measured. But again, I do want to point out that this was a secondary outcome of this study, so it does need to be interpreted with caution. This comes from the ESPGHAN review. It wasn't included in the European Food Safety Review, but they had a look at the different dietary, or they did a bit of an overview of the different dietary patterns during the complementary feeding period and later effects. And what they recommended is as a diverse range of food to establish good, healthy food preferences and eating patterns for later in life, and avoiding discretionary foods. So foods that are high in sugars, foods that are high in salt, snack foods, and sugar sweetened beverages. And what they found is that when there was an unhealthy dietary pattern, infants are more likely to end up with a slightly lower IQ. And where there's a healthy dietary pattern, infants are more likely to end up with an enhanced or a better IQ, and they do better at school. Now, these were observational studies only, so they do have a high risk of confounding for things like maternal and paternal education. Looking at timing of complementary feeding and micronutrient status, this wasn't covered in those 2 reviews, so I've included a reference to an actually quite a recent review that looked at this. And what they found is that for iron, there's a moderate level of evidence, so this is considered a reasonable level of evidence that there's no long-term advantage or disadvantage for introducing complementary foods at 4 months versus 6 months on iron status. And for a range of other nutrients, there's just not enough evidence to determine whether or not there's an ideal time. Looking at some of the specific studies that they included for iron, the observational studies, they found that most showed no association of the timing of complementary feeding and iron status, except that they found that if cow's milk was introduced before 12 months, there was an increased risk of deficiency. In the randomized control trials, they found no differences in iron status so long as they were all adequate, and most found no association between iron status and timing of complementary food introduction. Although there was some suggestion that starting at around 4 months increases serum ferritin in some infants, and that these infants are therefore less likely to be deficient later on. As has been mentioned, vegan and vegetarian diets are often discouraged during the complementary feeding period, and this is because the same nutrients are not as easily available in plant-based diets, and there can be long-term effects to brain development and growth. So if families do choose to use vegetarian and vegan diets during the complementary feeding period, it is really important that they seek expert medical and dietetic advice to make sure that their infant's not going to be disadvantaged. Now, looking at meat in particular as a complementary food, there have been a few randomized control trials looking at high meat diet versus low meat diet during the complementary feeding period. And they found that actually there was quite comparable iron and zinc status for the infants between these groups, and especially when there was meat and fortified infant cereal available to both groups. In observational studies where they've looked at frequent versus infrequent meat as a complementary food, they did find that iron status is likely to be higher when meat is frequent, and infants are less likely to have iron deficient anemia. And where there are observational studies of meat during the complementary feeding period versus no meat, iron status was likely to be higher. However, in those observational studies, they didn't make it overly clear whether or not infant fortified cereals were available to the populations or what their source of iron was. So what are the conclusions? Basically, there's no exact age that's ideal for introducing complementary foods. Whenever an infant is developmentally ready to accept complementary food is the ideal time, basically. And it's generally accepted that that is somewhere between 4 months and 6 months of age. So the studies that did look at effects for infants that were less than 4 months of age when complementary food was introduced generally indicate that it's not ideal. Infants do tend to do better when they're 4 months. But complementary food shouldn't be introduced after 6 months of age. And it is also important, we know now, that complementary food not only includes iron-rich foods, but that it includes foods that are of concern for allergens, even in families of high risk of food allergies. So what are parents actually giving their children during the complementary feeding period? So Nestle's own FIT study has been great at doing a lot of work to actually uncover what is being provided to young children. I'm going to talk about results of the US study, but there is one in the Middle East that is apparently going to be ready to share some results soonish. But this one in the US is now up to its 3rd round of data collection. And what they do is do dietary recalls for a range of infants. I think this one was 0 to 5 years. I'm only going to be talking about infants in the complementary feeding period, but over 3,000 households in the last couple of years. These households were quite representative of US households. So this is considered quite robust data. So in that 6 to 12 month period, it was, even in a country like the US, it was a bit disappointing that it looked like, about a quarter of the infants are not getting enough iron. Beef was not a common food that was provided, and even infant fortified cereal was only given to 50% of the infants surveyed. A third of them were not eating vegetables. A third of them had had fruit juice, even though it's not recommended in young children. Almost a fifth were receiving cow's milk, even though it's not recommended under 12 months of age. And almost 15% had had a sugar sweetened beverage. So not exactly ideal. And almost a fifth also receiving complementary foods before 4 months of age. In the 2nd year of life, there was still around 20% who had not eaten a serving of fruit in the last 24 hours, a third who hadn't eaten a vegetable, and of those who had eaten a vegetable, 2/3 of them had had something other than white potato. So a third of them are eating things like mashed potato and fried potato, which is not exactly ideal. There was also about a third who had had a sugar sweetened beverage as well. If you look at the sorts of vegetables that were the most common to be consumed across those complementary feeding periods, potato really is the main vegetable, followed closely by carrots and green bean, but You can see as infants here are becoming more accepting of crunchy foods and foods that they can chew. They're more, they're receiving more fried potatoes. So not exactly nutritionally recommended foods. Now, looking at iron, it was interesting that provision of iron in complementary foods seems to be decreasing over the last few years. And the infants that look like they're not getting enough iron are increasing. And it seems like much of this might be through infant cereals are not being used as much as what they used to. Intake of beef is consistently being quite low between the 3 different time points, but infant cereals are decreasing, and it doesn't seem like there is an increase in other sources of iron in the diet. So it suggests that there's a little bit of work to be done to make sure that infants are getting enough iron, to make sure that they're not being provided with sugar sweetened beverages and high sugar snack foods, that they shouldn't be having cow's milk before they turn 12 months, and after they turn 12 months they're probably not getting enough cow's milk, and all of them need to eat more fruit and vegetables. So what are our key take-home messages? At the moment, introducing complementary foods should be sometime between 4 and 6 months. And this really means after 7 weeks of age, but before 26 weeks of age. And, depending on the infant, whenever they're developmentally ready, complementary foods should include allergenic foods. These shouldn't be avoided, even if parents are concerned that their child will develop a food allergy. And iron-rich foods should be included in the early complementary foods, whether that's meat or infant cereals that have been fortified. If an infant is looking to be at risk of having low iron, it might be prudent to introduce iron-rich complementary foods closer to 4 months rather than 6 months. And if they're at risk of iron deficiency anemia, you might want to consider testing and possibly supplementing them with iron to make sure that they don't go on to develop anemia. All right, thank you all. Looking forward to a bit of a discussion.
Thank you so much. I mean, it was an amazing presentation, and we have great participation from our audience. I have tried to answer some of the questions as we went along, but some important points we would like to stress from you as well. So I will ask the questions as we go on, but I would like to mention a couple of interesting points. I mean, breastfeeding, not only gives you the milk and the nutrition, but it also gives you the taste and flavor what the mother eats. So that's a very important point to consider, because the children like the foods, the babies seem to like the foods that the mother likes to eat more during the breastfeeding period. So this is important to consider, another factor to consider breastfeeding. And regarding iron deficiency, I would like the pediatricians to stress to their obstetric colleagues the importance of delayed cord clamping, because obviously that's a very important step we can do right at birth to reduce the risk of iron deficiency anemia later. And of course, it's interesting to see your slides on infant cereal intake reducing, and so we are seeing an increased risk of iron deficiency. So do you think it's due to a cultural change, or is it a taboo that people want to give more homemade foods? Of course, a good balance is always important. What is your view on that?
I actually have no idea. It could be a number of things, but yeah, you're right. It could be that more parents are now wanting to provide homemade foods rather than purchasing fortified cereals. Yeah, unfortunately, I don't think that the reasons for choices were measured in this study, but it will be really interesting to see when the data from the Middle East come out, whether or not this is an international trend or something that's quite specific to maybe the US. I know we're doing a similar study in Australia at the moment. So hopefully once we can bring a few different studies together, we'll be able to get a bit more of an insight.
one question on how often do you recommend iron-containing foods per week if you don't recommend supplementation as standard to babies during the complementary phase? So I think you covered it in your slides, but can you reiterate that?
Yeah, I think in Australia it's just about every day. And if you're worried that the child is likely to be low in iron, it's 1 to 2 serves a day of an iron-rich food.
So basically, I mean, either one portion of meat in the morning and the lunchtime, or maybe a portion of infant cereal in the evening, or the other way around. So two portions a day.
Yeah.
And is there a difference in IQ between breastfed and not breastfed children at 7 years of age? I know it's a tough question.
Yeah, it is a tough question. So there's a lot of mixed evidence around breastfeeding and IQ. There have been some studies that have shown that babies do tend to have a higher IQ if they've been breastfed, but that does need the caveat that there tends to be differences between women or between families who choose to breastfeed and who use formula that could be confounding that association. So it's up for debate. I think still we don't really know yet, and we can't do a randomized control trial where we give half the baby's breast milk and half the baby's formula.
That's true. And if the mother has iron deficiency anemia and the baby is breastfeeding, the question is, does the infant also get iron deficiency anemia? So I've answered to that it's breastfeeding is an active process, the milk production, but the mother's activity level and her tiredness might affect the interaction. So what is your take on that?
Yeah, definitely. I think, iron levels in breast milk are quite low anyway, so it's probably for iron status, it's probably more important the mother's iron levels during pregnancy. But definitely if a mum is deficient, she is probably less likely to be responsive to her baby if she's feeling fatigued all the time. So if possible, it would be, not only important to make sure that the baby has sufficient iron, but improving the mum's iron intake would be really important as well.
Thank you. And I mean, I know this was not discussed today, but where the infant is getting a low lactose infant formula for colic or say after diarrhea or something like that, does it affect the brain development? I mean, what's your point of view?
That's a really good question. I have to admit, I'm not sure. I'd have to do a bit of research and get back to you on that one.
Because there are some studies which say at least 2% should be there. I mean, if you use a lactose-free formula, use it for a very minimal period of time. But if you use a low lactose formula, it should be reasonably okay, is what I understand. So there is one question about vitamin D for formula-fed babies. I mean, obviously, the recommendation is to supplement both groups till the baby gets at least 1 liter of formula, which will probably be around 4 to 5 months, isn't it? So what is the Australian recommendation on that in formula feeding babies and vitamin D supplement?
Yeah, actually, I'd have to get back to you on that as well. It's changed over the last little while in Australia. So I'm sorry, I don't have that.
So the reasoning for supplementing in formula-fed babies is that the 400 units is reached only when you reach around 800 ml to 1 liter, which is usually consumed by around 5 months of age. And by then the complementary feeding might start. So actually it's better to supplement vitamin D even in formula-fed babies is a recommendation in most centers. And one final question from the earlier messages. I look at the question session now as we go on. I mean, is there any study on zinc supplementation and final adult height?
Not that I know of for height, no.
Yeah, not that I know of as well, so we'll have to pass that. How to determine that the infant is developmentally ready for feeding? So I did mention it in the beginning, and so some of you had asked about whether the slides will be available because they had a disruption. So I'll discuss with Dr. Taufik and see if we can make it available in the Nestle Nutrition Institute website or another portal. So I'll get back to you on that after the meeting. Maybe Dr. Taufik will arrange a message to all the registrants. Does egg white have any side effects that is harmful to the infant kidney? Okay. Thank you.
Yes, we will hopefully have it on the NNI website soon. So just to be prepared with making it onto a live, onto a shooted session, we'll upload it hopefully in a couple of weeks.
That's fine. How much time do we have for the discussion? I know it's really late for Dr. Gold because there are 10 more questions as we were speaking. So
maybe
what do
we
you
can
think?
have
Another
10
5
minutes
minutes?
more, or
Yeah,
if one question,
another
1
5 to
minute,
10
that would be
minutes.
great.
Okay. So again, there is a question about supplementing infants with vitamin D even when they're exposed daily to the sun. So the answer to this, I will answer that. I mean, basically, exposure to sun to produce vitamin D, you need 20 to 30 minutes in the time between 10 a.m. to 4 p.m. or so, which is very unlikely to happen even in a sun-rich country like the UAE because of the heat damage. And also, dark-skinned races are less likely to produce enough vitamin D. So better not to rely on sun in the babies or infants. That adults possibly could do, but not for the babies. And why some infants, okay, head is long, that's not relevant to the presentation. For how long should we provide iron for the term and preterm babies, Dr. Gold?
Well, really, iron should be a food source in the diet forever. For preterm babies, you might want to consider supplements, and you probably really only want to supplement them long enough to make sure that their iron status is corrected and it is adequate. For term babies, you probably only want to supplement them if they are at risk of, like, seriously at risk for other reasons of having iron deficiency, and then you wouldn't want to supplement for longer than is needed.
Thank you. I mean, that also answers another question on iron and preterm for how long. I mean, so it would be reasonable to say that make sure you supplement iron till 1 year and at least make sure the diet is adequate beyond 1 year of age and have a good mix. So is there any reversible changes that could happen with iron deficiency if you don't correct it early? So they're asking about irreversible changes.
Yeah, look, in animal models, changes don't, during the complementary feeding period equivalent, like in rats, for example, changes do seem like they last into adolescence and adulthood. So I guess it's really hard to say. It depends exactly maybe on when you detect the deficiency and when you can intervene, how deficient, other aspects of their home environment and their nutrition, and how advantaged or disadvantaged they are otherwise.
It's a good answer, and obviously we should remember the programming effect of early deficiencies. So it's not just related to the actual deficiency at that time, as we know that programming can change your behavior for life, or the different functions of our body organs can be modified. So we should supplement as best to avoid deficiency in the early stages. So just the last question, I mean, you mentioned about the pattern of complementary feeding, that you start with a certain volume and go up. So there is a question related to the same. So I know there are a few other questions that came up, but due to the time constraints, I think this will be the last question. So if you can guide us on the sequence, how many feeds of complementary feeds versus breast or formula feed, and how you'll phase out?
Yeah, so I think at the moment our advice is that you provide complementary feeds when the infant looks like they're ready. And so what you would do normally is provide them with a breastfeed or a milk or formula feed, and at the end of that you would start introducing maybe a spoonful of a complementary feed, and you would gradually increase this so long as the infant looks like they're ready and they're hungry for this. You wouldn't necessarily phase out breast milk or formula until they're around 2 years old or even older, and particularly if they're breastfeeding. There's not really a specific ratio, I don't think, but in the early period especially, you don't really want complementary foods to be replacing breast milk or formula. So you want to make sure that that really is still the primary source of nutrients for the infant until they're at least 12 months old.
And do you have any comments? There was one question on babies who are difficult to give complementary foods to. I know it's not your area. I mean, I know psychology is your area as well, sorry. So do you want to give any tips on that part? Sorry.
Yeah, so at the moment, our recommendations are that you provide it, that providing complementary food is very responsive. So what you would do is offer foods to an infant, and then they choose what they do and don't eat. But you do need to make sure that what you're providing them is nutritional, it's a good variety, and that you're not offering them, you know, like a carrot and a cookie, for example. You want to keep the options quite similar. And it is really common for infants and young children to refuse food, a specific food, like 10 times before they might try it. So just keep offering them the food, eat it yourself so that they can see you modeling the food. And your suggestion of competition with siblings and twins is excellent. There are some infants and children though, where if they have neurosensory, if they're quite sensitive, then they might actually need a little bit of assistance for the parents to help with complementary feeding, because there are some children, particularly with autism spectrum disorders, for example, where specific textures are just so unpleasant for them that they would rather not eat, even if that means that they're incredibly hungry. And that does need to be handled quite differently. So, you know, parents should just keep trying and be persistent, not force feed, offer their children food. And if it does seem like there are maybe other issues, then they probably do need to go speak to a doctor or a pediatrician.
It was perfect. Thank you so much. And I mean, obviously, screen time shouldn't be encouraged at all while feeding, and don't give food as a reward as well. I mean, very valid points, and thank you so much for your participation. And I would like to thank the audience and people who are here. 500 plus numbers from the start to the end is an amazing success. And so many questions, so many intelligent questions, and thank you all for the participation. And I would like to thank Dr. Tawfiq and the team for setting this up, and look forward to the video on the website so people can gain more from it. I would hand over to Dr. Tawfiq now, and thank you, Dr. Gold. It was a pleasure interacting with you.
Yeah, thank you.
I thank you so much, Dr. Sridhar, and thank you, Dr. Gould as well. Probably we had a heavy meal of weaning today, so it's a great engaging session, as you know, we all had today. So thank you so much for the audience, and thanks for the questions. Thanks for the speaker and the chairperson as well, who moderated this session very well today. So we look forward to have more sessions together, and hopefully in the near future we get to see each other face to face in common meetings in one meeting room in the near future. Thank you so much, and probably we took some extra time and we prolonged the session for a while, but it was pretty engaging today. So thank you so much.